Okay, hello everyone. I think this is our fourth one. Wow, a lot of material here. We're going to now talk about another different group called mitotic inhibitors, which would be, of course, we know mitosis is cell replication, and these are cell cycle phase specific. They act on that M phase to prevent cell division. Two groups of these are the vinca alkaloids and the taxanes. Vinca alkaloids are old drugs that have been around for a very long time and very, very, very effective. Vincristine and vinblastine, they're like sisters. They block assembly of microtubules that move chromosomes during cell division, so they don't allow them to move. These drugs, again, are M phase specific, and they work a little bit differently. Vincristine is toxic to peripheral nerves, so causes neuropathy, but does not significantly suppress bone marrow function. So you can see why these drugs might be very good against something that's going on in the bone marrow already. Vinblastine causes significant bone marrow suppression, but is harmless to peripheral nerves. So you can see that they're very different, even though they're like sisters. And thank goodness they are a little different. Otherwise, we wouldn't be able to use them for almost all cancers. Vincristine, again, is the one. It does not suppress bone marrow, but causes peripheral neuropathy. So because it doesn't suppress the bone marrow, we can treat it for Hodgkin's, which is the lymph nodes. Non-Hodgkin's, both Hodgkin's and non-Hodgkin's, and we'll talk about that as just a different type of cell a little bit later. ALL is acute lymphocytic leukemia, again in blood. Wilms tumor can be on the kidney, which kidney we know is full of blood. Rhabdomyosarcoma. Kaposi sarcoma is the one that goes on from people with AIDS in the lung. Breast cancer, bladder cancer. Peripheral neuropathy, again, is dose limiting. It's kind of like, how my sister is saying, the neuropathy is going to her ankles. So how much of this can she tolerate? She has not been on vincristine or vinblastine, though. But again, drugs can be dose limiting depending on what we're doing to the vital tissues, the ones that are viable, that are working well. Vinblastine will also treat Kaposi sarcoma, Hodgkin's and non-Hodgkin's, cancer of the breast and testes, and because of the bone marrow depression that it does have, it's dose limiting. Other mitotic inhibitors, the other group are the taxanes, Taxol, Onsol, Abraxane, widely used drug that acts during the late G1 and M phase to promote formation of stable microtubule bundles, inhibiting cell division and producing apoptosis, I would imagine, at the M phase. Paclitaxel with cisplatin is approved for advanced ovarian cancer and non-small cell lung cancer, also used for second-line therapy for AIDS, again related to Kaposi sarcoma that came as the aftermath of AIDS, Kaposi sarcoma. Adjuvant therapy with doxorubicin for women with breast cancer, so in addition to. Some miscellaneous cytotoxic drugs are asparaginase, converts asparagine into aspartic acid and thereby deprives cells of asparagine needed to make proteins. And if they don't have the appropriate proteins, they can't grow and divide. Other anti-cancer drugs we'll just lump all together. Hormonal, biologic response modifiers, and others are mostly cell cycle phase non-specific. They lack the characteristic toxicities of the cytotoxic anti-cancer drugs, such as bone marrow suppression, stomach problems, inflammation of the whole GI lining, and severe nausea and vomiting. Hormonal cancer drugs act through specific hormone receptors on target tissue, so it depends on what we're looking at. Actions are fairly selective, and toxicity to normal cells is low. Breast cancer treatment, because it's so prevalent, we're going to look at that. And with some of the hormones that we talked about, receptors on target tissues, anti-estrogens block estrogen receptors, whereas aromatase inhibitors block estrogen synthesis. For either group to work, the cancer must be estrogen receptor positive. Fulvestrant is a, let's see, did I list that in here? Yes, I did. It's over in this one, so I'm going to move on for a minute. Fulvestrant poses no risk of endometrial cancer and only a slight risk of thromboembolus, where some of them do. And again, two hormonal agents are two types, are anti-estrogens and our aromatase inhibitors. In the anti-estrogen, there's two major categories: pure estrogen receptor antagonists, so they're antagonizing the estrogen receptor, doesn't let it work at all, or a selective estrogen receptor modulator. Fulvestrant is the one approved for treatment of breast cancer, but not for prevention. The selective one, or SERMs, block estrogen receptors in some tissues and activate estrogen receptors in others. Tamoxifen is approved for prevention and treatment of breast cancer. So tamoxifen is kind of like the gold standard of women, of what women take after they've had breast cancer, and it's they try to keep those cancer cells at bay. It's been around for years, and it is the gold standard for people with breast cancer to take. Once they're done with it, they may have to take it for life. Raloxifene is also a SERM, a selective estrogen receptor, decreases the risk of breast cancer, carries a lower risk of uterine cancer compared to tamoxifen. Safer than tamoxifen for breast cancer prevention. Okay. By activating certain estrogen receptors, tamoxifen increases the risk of endometrial cancer and thromboembolism. So a lot of times what they do with these breast cancer women is they'll go ahead and do a hysterectomy because they want them to take the tamoxifen, and if we know tamoxifen may cause uterine cancer, well, they don't need that. And unfortunately, folks, it quite often, somebody that's had one cancer sometimes can get another cancer. Okay, let's see. And again, tamoxifen is considered the gold standard for endocrine. Let's go back a minute. Yeah. For endocrine treatment of breast cancer, used for established disease and for primary prevention in women at high risk. It is a prodrug that undergoes hepatic conversion to active metabolites. These metabolites block estrogen receptors on breast cancer cells and thereby prevent receptor activation by estradiol, the principal endogenous estrogen. Estradiol, endogenous means it's produced inside our bodies. Estrogen acts on tumor cells to stimulate growth and proliferation. Okay, now going on to our aromatase inhibitor. Before we do, let's see, what are these drugs? They're used to treat estrogen receptor positive breast cancer in postmenopausal women. They block the production of estrogen from androgenic precursors, thereby depriving breast cancer cells of the estrogen they need for growth. So they're going to block that androgenic precursor. And so in doing so, the estrogen will not be released for growth. These aromatase inhibitors do not block estrogen made from the ovaries, and that is why it won't work in premenopausal women. They pose no risk for uterine cancer, rarely cause thromboembolism. So this anastrozole, used to treat estrogen receptive positive breast cancer in postmenopausal women only. It's more effective than tamoxifen and poses no risk of endometrial cancer. May cause osteoporosis and fractures and and basically what they're saying is this one does not have to do with ovary production of estrogen, because they're postmenopausal, so they're not producing that estrogen. And this other one, we used to call this TMAB because nobody can say that term. It's a monoclonal antibody originally approved for metastatic breast cancer. It is only effective against tumors that overexpress human epidermal growth factor that helps regulate growth. And this one is in addition, sorry about the typo, guys. In addition to the anti-estrogens and aromatase inhibitors, breast cancer may be treated with this. So again, it's a bundle of drugs. Major effect of this TMAB drug is cardiac injury manifesting in ventricular dysfunction and heart failure. So again, whenever a drug has that type of side effect, we're going to be checking their EKGs and putting them on stress tests and so forth and so on. Okay, we have to look at our glucocorticoids. We know this is main drug for, we use it a lot systemically for inflammation, and this one can be toxic. Glucocorticoids can be toxic to cancers of lymphoid origin, acute and chronic lymphocytic leukemias, so ALL, ACL, Hodgkin's disease, non-Hodgkin's lymphomas. Also used to manage complications of cancer and cancer therapy. It can suppress the chemotherapy-induced nausea and vomiting, so we give them this. We can give them glucocorticoids to, glucocorticoids also promote a feeling of well-being. Reduction of cerebral edema secondary to irradiation of the brain. Reduction of pain to nerve compression or edema. It's a potent anti-inflammatory. It suppresses hypercalcemia in steroid-responsive tumors. Improves appetite and promotes weight gain. That's where that whole general feeling of well-being comes in. And again, imparts a generalized feeling of well-being. So again, glucocorticoids are used to manage complications, which are all listed here. Also toxic to cancers of lymphoid origin. It also increases susceptibility to infection. So we've got to be very, very careful there, because we know it suppresses inflammation. That's how it helps with the pain. But in doing that, in suppressing the inflammation, it's going to suppress the good inflammation too, that are fighters. So it can actually increase susceptibility to infection. When glucocorticoids are used acutely, their toxicity are both mild and manageable. When they're used very long-term, it can cause bone softening, which is osteoporosis, adrenal insufficiency, increased susceptibility to infection, which I just alluded to, and peptic ulcers, so it can cause us to bleed. Androgen deprivation. We're going to use this for prostate cancer. If it's advanced, they may treat the person with castration or drug therapy. I mean, castration, who wants that? Where they literally, rearrange men's body parts. Early localized treated with surgery. Irradiation may be followed with androgen deprivation. Androgen deprivation can be achieved with two types of drug. Our GnRH agonist, which we know an agonal medication is going to push it forward, and our androgen receptor blockers. Androgen is testosterone or androsterone. It's a hormone that promotes male characteristic. The gonadotropin releasing hormone is a growth hormone, not a sexual hormone, but it will actually send the message from the hypothalamus to synthesize and release the GnRH transmitted to the anterior pituitary to produce secretion of testosterone. Okay, I'm going to stop here, and then we will finish with one more, and then it's all done. So hang in there with me.